So welcome to LVS Journal Club. I'm Laura, and this journal club's got a bit of a theme of immune-mediated thrombocytopenia. So our first journal paper is on the detection and dynamics of anti-platelet antibodies in IMTP dogs, and that's with primary and secondary immune-mediated thrombocytopenia. So just in the introduction, anti-platelet antibodies have been detected in both dogs and humans with and without IMTP, and also in primary and secondary IMTP. And they suggest a kind of role of the immune response in the pathology of IMTP. Previous studies have suggested that they're not a very accurate way to differentiate between primary and secondary forms of IMT. So in humans, APAs have been documented in about 60–70% of people with primary IMTP, and they potentially suggest contribution of cell-mediated destruction, or this potentially suggests that contribution. And there has been a potential possible relation to prognosis, response to treatment, and recurrence or relapse in people, although this is still being researched. So the aims of this paper were to evaluate thrombocytopenic dogs for the presence of APAs and characterised how they change over time in primary IMTP dogs, and also determine if the presence of APAs is related to the response to treatment of IMTP and relapse or recurrence rates as well. So dogs in this study were selected first of all based on whether they were thrombocytopenic, and then both dogs with suspected primary IMTP were chosen, and dogs with diseases related to IMTP, so potentially secondary IMTP cases. And those included dogs with infectious diseases and neoplasia, which have been confirmed by previous testing. And then listed are the definitions for thrombocytopenia for each group of dogs. And APAs were detected using flow cytometry. And dogs were defined as either positive or negative for APAs based on their percentage. So less than 10% they were considered to be negative, and over 10% they were considered to be positive. And then looking at the primary IMTP dogs, APA measurements were taken at 4 different time points, and the response to treatment was defined as platelets returning to over 200,000 per microliter within 4 weeks of initial diagnosis. Persistence of APAs was defined as presence of them 4 weeks after starting IMT treatment, and recurrence was defined as presence of APAs after a dog had been previously negative. And then relapse was defined as dogs who had a documented normal platelet count, and later on in rechecks their platelets had returned to less than 100,000 per microliter. And all dogs in that primary IMT group had to be negative for antibody testing to Anaplasma, Babesia, Bartonella, Ehrlichia, and Rickettsia. And they'd all gone through abdominal and thoracic imaging to rule out secondary causes of IMT. So just as a summary of the results for dogs with thrombocytopenia with concurrent diseases, so potentially secondary thrombocytopenia, and looking at the occurrence of anti-platelet antibodies in these dogs and median platelet counts. So dogs included in this group, there was a total of 79 dogs overall, and this included dogs with infectious diseases, neoplastic diseases such as osteosarcomas, anal gland adenocarcinomas, and disseminated carcinomas. And in the infectious group, a reasonable number, so 47% of this group, were positive for APAs, and the median APA percentage was 17%, so still quite low. And then in the neoplastic group, again, only 4 dogs, so 14.8% of this group, were positive for APAs, and the median APA range reflects this. Median was 4.2%. And then in the other group, this was quite a diverse group of dogs with considered secondary thrombocytopenia. So it included dogs with pancreatitis, pyelonephritis, and one dog with a rattlesnake bite as well. And Of that group, again, quite a low number, so 10.8% were positive for APAs, and the median was 1.8%, so fairly low. And then in dogs with primary IMT, 28 dogs were included in this group, but 6 were lost to follow-up, and the signalment is there. Median platelet count was fairly low at 8,000. And interestingly, all dogs in this group were positive for APAs. The median percentage of APAs was 37%. And in this group, in terms of response to treatment, 82% of the dogs responded to treatment. The APA percentage was statistically different at time points between 4 responders and non-responders, but not at the initial diagnosis. So, sorry, between time point 4 between responders and non-responders, but at initial diagnosis there was no significant difference in APA percentage between those who responded to treatment and those who didn't. And in responders, the percent of APA at initial diagnosis was statistically higher than at time 2 and time 4. So within that group, they seem to have a higher number of antibodies at the initial diagnosis compared to later on in the study. There is no significant difference in response to treatment with or without persistent antibodies. And so we have to discount the last bullet point. So there was a difference in platelet count between responders and non-responders. So 4 of the dogs that responded to treatment and 2 of the dogs that didn't also displayed persistence of anti-platelet antibody later on in the study. And 2 of the 22 dogs had a relapse, which was also associated with a recurrence of antibodies in both dogs. So in one dog, the relapse occurred 17 months after the initial diagnosis, and then another one a year after. And in the second dog, the first relapse occurred 10 months after the initial diagnosis. Both dogs, interestingly, had been negative for anti-platelet antibodies at the time of the initial diagnosis, but both were positive when they had a relapse of INT. And then in terms of survival to discharge data, the initial percentage of anti-platelet antibodies at diagnosis was not significantly associated with survival to discharge. Dogs that didn't survive to discharge had a lower percentage of anti-platelet antibodies compared to survivors, although this difference wasn't significant. And interestingly, they did find that melena at initial evaluation was associated with a decreased rate of survival to discharge in primary IMTP dogs. So some of the conclusions the authors made from the study was that the percentage of APAs varied and had varying amounts of overlap between the different categories of secondary IMTP dogs. So you couldn't really use it to distinguish between the different secondary causes of IMTP. There were no significant differences between the causes of thrombocytopenia. So this includes primary and secondary in the percentage of APAs. And as you said, you can't really use APAs based on this study to differentiate between primary and secondary IMTP. But given the kind of final bit of data in the study, it may be that they could be useful for determining relapse in future cases, although I think we need more studies to determine this. Moving on to our next paper, this looked at the application of therapeutic plasma exchange, or TP, in dogs with immune-mediated thrombocytopenia. So just some background, as we've already talked about a little bit, immune-mediated thrombocytopenia. So I hypothesized that antibodies bind to platelet surface epitopes and lead to platelet destruction. And based on this, IMTP treatment typically consists of immunosuppressive treatments. It has also been shown that vincristine and human immunoglobulin have decreased the time required to restore platelet counts in dogs over 40,000 per microliter. And a little bit of background on plasma exchange. So it's an extracorporeal treatment and occurs outside the body and requires special equipment. And the basis of it is to remove pathogenic substances from circulation, so that includes antibodies and antibody antigen complexes. And it's currently emerging as a treatment for immune-mediated disorders in dogs such as IMHA and myasthenia, but it hasn't previously been described in dogs with IMTP. So this paper looked at 4 case reports to describe therapeutic plasma exchange in IMT dogs, and these were performed between 2016 and 2018 at UC Davis. And the criteria for therapeutic plasma exchange in this study was that these dogs had an unresponsiveness to over 4 days of immunosuppressive treatment and ongoing hemorrhage with the need for 1 or more red blood cell transfusions. And each dog had 3 sequential TP sessions at day 0, 1, and then either day 3 or 4. And all dogs underwent plasma exchange of approximately 1.5 plasma volumes per TP session, aiming for a total of 80% decrease in antibody burden. All of the dogs in the study were also confirmed to be primary IMTP dogs with thoracic abdominal imaging and the exclusion of infectious diseases and neoplastic causes that might cause a secondary IMTP. So the first case was a 4-year-old female neuter Dachshund who presented with signs of hemorrhage and hyperexia. And then diagnostics, I have gone through all of them just for completeness, but we'll go through fairly swiftly. So CBC showed regenerative anemia, neutrophilia, and thrombocytopenia. And then on biochemistry showed a hyperbilirubinemia among hypokalemia and hypoglycemia. Echocardiography was performed in all of the dogs and was normal in this dog. And this dog was also tested with a Coombs, which was weakly positive, but agglutination was negative, and it was presumed to have primary IMTP rather than an Evans syndrome. So treatment, this dog had been treated by its primary care practice prior to presentation to the university, and its treatment was slightly changed, so it was remained on, was started on dexamethasone and remained on cyclosporine, but the doses were slightly changed. And then 3 days later, due to unresponsiveness, it was started on TPE. It had had 3 platelet transfusions prior to TPE because of severe hemorrhage. And it had a total plasma exchange of 4 volumes. In this case, the main adverse event was an episode of hypovolemia during the 3rd TPE session, which was responsive to a bolus of isotonic crystalloids. And hospitalisation was 7 days, including 4 days after starting TPE. Time to platelet count was about a week after starting immunosuppressive treatment, but 1 day after starting TPE. And it continued to improve later on after starting TPE. Clinical signs, including the regenerative anemia, resolved 1 day after starting TPE. And this dog appeared to do fairly well initially, but unfortunately was euthanized 45 days after discharge. And the paper reports this was due to signs that were speculated to be unrelated to the IMTP, so we don't have any evidence of recurrence. And then case 2 is another fairly medium-sized breed dog, which is a 10-year-old female neuter beagle. Had similar signs, presenting signs as case 1, although interestingly, it seemed to have an onset of signs after a prophylactic rattlesnake vaccine, which is a toxoid vaccine. And it also had developed a heart murmur on presentation. So diagnostics showed fairly similar changes to case 1, apart from a added hypoalbuminemia and hypocholesterolemia. And echocardiography did show some changes, so showed AIVR and occasional VPCs as well. And this dog presented to the university pretty soon after presentation at its referring vet service. So it was started on immunosuppressives, and then TPE was initiated 4 days later. It was also given 3 platelet transfusions due to severe ongoing hemorrhage, and it received total plasma exchange of 4 plasma volumes. Again, this dog did have an episode of hypovolemia during the first TPE session, which responded to boluses of isotonic crystalloids. Total hospitalisation time was 8 days, but unfortunately this dog didn't respond to treatments. It had a severe persistent thrombocytopenia and hemorrhage, and had a total of 22 packed red blood cell transfusions during hospitalisation. So unfortunately this dog did not make it to discharge and was euthanised 2 days later after the third TPE session. And case 3 was a slightly smaller dog, a 4.5-year-old female neutered terrier mix. Similar signs of hemorrhage on presentation and similar findings on complete blood count, biochemistry, urinalysis. Echocardiography was normal, and this dog had reported infectious disease testing and blood cultures performed, which were negative for secondary causes of IMTP. Treatment was very similar. Again, it was started on treatment at the university with dexamethasone and cyclosporine. It had one platelet transfusion before TPE was initiated to decrease the risk of hemorrhage during catheter placement. I think this dog had already shown signs of hemorrhage when intravenous catheters had been placed, so this was more of a prophylactic and less severe than the previous case. And TPE was started 4 days after immunosuppressive treatment because of ongoing hemorrhage. It did require 2 packed red blood cell transfusions in this time, and it received a total of 4.8 plasma volumes in exchange. This dog showed a different adverse event, which was vomiting and hypothermia, and suspected to represent a non-hemolytic febrile transfusion reaction. Unfortunately, they did not feel the need to stop the treatment during the third TPE session and seemed to recover post TPE. Hospitalisation was a little bit longer than the previous cases, so 11 days, including 6 days after TPE initiation, and it did take a little bit longer than previously documented for the platelet count to reach over 40,000 for case, or compared to case 1. Hematochezia also interestingly resolved 4 days after starting TPE, although platelet count took a little bit longer to increase. And in the long term, this dog appeared to do well, so platelet count was normal 6 months after discontinuing immunosuppression, and it was in remission at his last follow-up at 417 days post-treatment. And then the last case is another terrier mixed breed, which is a 6-year-old male neutered terrier mix, and had similar presenting signs, also with a grade 3 and 6 heart murmur. Diagnostics were fairly similar to the previous cases as well. And this dog had been at its primary care practice for the previous 8 days before presentation to the university, so had already been started on immunosuppressive treatment and received 3 packed red blood cell transfusions. This was then slightly changed when it was admitted to the university, and 3 days later TPE was started. This dog had a slightly higher volume of 4.9 and total plasma volume in exchange. And in this dog, one of the main adverse events was clotting in the extracorporeal unit on the second TPE session, which was thought to be due to low flow rate because of its really small size. So on subsequent infusions, a CRI of heparin was administered and no further complications were encountered. This dog was hospitalised for 7 days, and time to platelet count over 40,000 per microliter was 15 days, so a little bit higher than the last case and the first case, and occurred 7 days after starting TPE. Interestingly, again, the melena improved more quickly within 2 days of starting PPE, even though platelet count was 10,000 with some clumping. In the long term, this case also seemed to do well and was still in remission at its last follow-up 87 days post-discharge with a normal platelet count. So potential conclusions that the authors have drawn from this case series are it's a useful first report of TP use in dogs with IMT. And the main adverse events consisted of hypovolemia and the non-hemolytic febrile transfusion reaction, as well as clotting in the circuit. In 3 of the 4 dogs given TP and immunosuppressive treatment, platelet counts and clinical signs resolved. And it suggests that TP may be rational in IMT cases. However, they acknowledge that further studies are needed to explore this further, but it's an interesting account of its first use in this condition. And then the main disadvantages at the moment would be the expense of the treatment and the equipment needed, which is fairly specialised. So our third paper is on the use of platelet products in thrombocytopenic dogs, and it looks at lipophilised platelets versus cryopreserved platelets for management of bleeding in thrombocytopenic dogs, and it was a multi-centre randomised clinical trial. So just as some background, in humans, platelet transfusion is used as a component of hemostatic resuscitation for major bleeding, and below are some of the criteria in which it's used in people. And the prevalence of thrombocytopenia in small animal critical care medicine is 5 to 7%. Currently, platelet products for dogs include canine cryopreserved platelet concentrates, which is CPP, currently available in the USA. There was a product called paraformaldehyde stabilised lipophilised freeze-dried platelets, but that's no longer available, and it had been tested compared to CPP in dogs. But we do have a new Trehalose stabilised product that has recently been developed, although it's not commercially available, and that has not yet been used in comparison to the CPP. And this paper hypothesised that the new LP products would not be inferior to CPP for a reduction in clinical bleeding score, need for further transfusions, or survival to discharge when used in thrombocytopenic dogs. So as we said, this was a prospective multi-centre randomised but open label trial, and that was simply because the 2 products were really different in their form and appearance and administration, so it was really difficult to blind the administrators to which one was being given to the dogs. And the main inclusion criteria were dogs that weighed between 2 to 45 kilograms with a platelet count of less than 50 times 10 to the 3 per microliter, and had a doggy bat score of over 2. So the doggy bat system is a standardised bleeding assessment scoring system that this paper used, but comes from a 2018 paper by Milkowski et al., which we'll go through in a moment, but that formed one of the main bases of this study. And then the exclusion criteria for this study were dogs that had concurrent severe anemia, or had previous blood product administration within 72 hours, surgery within the previous 48 hours, or on treatment for congestive heart failure, hypertension, as well as abnormal coagulation parameters, and the administration of the medications listed on the bottom line. And this is just the doggy bat score, just to cover this before we move on. So this is from the 2018 paper, and each area that's used for the score is given a grade from 0 to 2, and 2 is severe, and it should give a maximum score of 18. And this was used in this current study to help evaluate the patient and use as a variable between the 2 platelet products. So dogs were given either CPP or LP by injections. The LP or the CPP was an infusion, which took longer to administer. And then doggy bat scores and buccal mucosal bleeding times were performed before administration, 1 and 24 hours after. And then a CBC PT and APTT were collected for each of the dogs at different time points. When possible, and depending on the centre in which those dogs were in, a TEG or TD were also performed, but that was a little bit variable depending on site. And then all dogs had a phone follow-up 7 and 14 days post-enrolment into the study. And the main things that were measured in the non-inferiority trial were the between-group difference in the pre-transfusion to post-transfusion doggy back score, and then the group difference between pre-transfusion, post-transfusion platelet counts, and the relative risk for additional red blood cell transfusions within 24 hours, and between group relative risk for all-cause mortality as well. And then these variables were also compared between pre and post-transfusion states in both groups receiving the different products. So moving on to the results, a total of 88 dogs were included in the study, and they recruited 50 dogs that were that received the LP product and 38 dogs that received CPP. And median age was 7 years old. Final diagnosis was not actually available for all dogs, so we know they were all thrombocytopenic, and that most have primary and secondary immune-mediated thrombocytopenia, but we don't have the exact diagnoses. And then this table, it does contain quite a lot of information, but it's just a summary of the inferiority trials and the difference between all groups. So interestingly, with doggy back scoring, there was a greater decrease in the LP group between time 0 and 1 hour after LP administration when compared to the CP group, but there was no difference between either group at 24 hours. And it was concluded that the LP product was not inferior compared to CPP in terms of doggy back score. And in platelet counts, no difference was seen in either at either 1 hour or 24 hours post product administration between either group, although there were differences seen within the groups. And then there was no difference in case fatality between either group. Interestingly, the LP group showed a lower decrease in hematocrit from time 0 compared to 1 hour after LP administration, and when compared with the CPP group, and it was hypothesized that might be because of the lower volume of LP administered, causing less hemodilution. Significant differences were found within both groups between the baseline 1 and 24 hours compared to hour 0, and there was no difference in the number of rescue platelet and product transfusion needed in either group. Interestingly, duration of hospitalisation was slightly longer for the LP group than for the CPP group, which was hypothesised to be potentially guided by the clinicians, and maybe that they kept a closer eye on the dogs that received LP compared to CPP, but this wasn't a significant difference. And there was no difference between leukocyte and neutrophil counts, although there were significant differences between baseline and subsequent time points within each group, but no difference overall between CPP and LP, and no difference in TPR between the groups as well, although again within groups there was significant difference from the baseline compared with subsequent time points. So discussion of potential implications of this study. So the study concluded that LP was not an inferior product to CPP in judging by the variables used, which provided possible implications for future use if it became commercially available. And based on the doggy back score, hemorrhage decreased in most dogs after LP transfusion. So in terms of the doggy back score, it achieved the same. And then the study also talks about the fact that most dogs also received concurrent other immunosuppressants, so including miltefosine and glucocorticoids, and some with or without vincristine, which they suggested could have affected the findings, although there was no significant difference between the groups in the number of dogs receiving vincristine treatment. So they compared the number of dogs receiving vincristine in both groups, and there was no significant difference there. And then on to the final paper. This looked at neutropenia in dogs receiving vincristine for the treatment of presumptive immune-mediated thrombocytopenia. So as a bit of background, vincristine is generally used as an immunosuppressant and works by inhibiting microtubule assembly and disrupting the mitotic spindle. It's often used in multi-drug chemotherapy protocols at doses of 0.5 to 0.75 mg per meter squared. And toxicity has been reported in healthy dogs at 0.1 to 0.2 mg per kg. It's not been previously documented when it's only been used for IMT, although that's quite limited in terms of studies. And myelosuppression is the most common toxic side effect that's seen, though neurotoxicosis can also be seen. Most commonly, neutropenia is seen as a form of myelosuppression. So further background, IMT in dogs is usually treated with glucocorticoids or other immunosuppressors, as we've seen from the previous studies, and a dose of vincristine at 0.01 to 0.02 mg per kg IV. So the proposed mechanism of action for vincristine in increasing platelet counts are listed below, although we don't 100% know which of these sort of has most effect, but it's hypothesized that it causes fragmentation of megakaryocytes, an inhibition of platelet phagocytosis, and an inhibition of antibody binding, as well as stimulation of thrombopoiesis. And the aims of this study were to assess the incidence of neutropenia in IMTP dogs treated with vincristine, and identify any other risk factors in these dogs for the development of neutropenia, as well as determine if the case outcome changed with the development of neutropenia. So this study was conducted at North Carolina State University Veterinary Hospital, and the electronic medical records were searched for dogs diagnosed with thrombocytopenia between 2003 and 2018. And they had to have at least one CBC performed at the university, but a minimum of total 2 complete blood cell counts accessible in the records. They had to have platelet counts of less than 15,000 platelets at the initiation of treatment, and had to have had a biochemistry performed and vector-borne disease testing, as well as bicavitary imaging to establish it was primary IMTP, and there were no findable secondary causes. And they had to receive vincristine at 0.01 to 0.04 mg per kg. The exclusion criteria included findings of any concurrent diseases which could lead to a secondary IMTP, or dogs that presented initially with concurrent neutropenia, had not received vincristine, or had been previously treated with vincristine. And neutropenia was defined as less than 2,800 cells per microliter, and then split into these 4 different grades listed below. And logistic regression models were used to look at the effect of factors on the outcome of neutropenia in dogs treated with vincristine. So the factors that were looked at were presence of hyperbilirubinemia, administration of other immunomodulatory agents, and vector-borne disease status. And then within the neutropenic group compared to non-neutropenic group, the dose of vincristine used was compared, days to platelet count over 40,000 platelets, was compared, duration of hospitalization, and survival rates was also compared. So the study population consisted of 127 dogs within the study group with a mean age of 8 years old, and 27 of these dogs were positive for 1 or more vector-borne diseases. 19 in total of these 127 dogs became neutropenic, which was a little bit less than had been previously reported in other studies. And the vector-borne diseases they were present for did vary. So I think Borrelia and Babesia and Ehrlichia were among them, and positivity was established by antibody testing. Not all dogs were tested for the same vector-borne diseases as well. So cyclosporine administration was interestingly found to be significantly associated with dogs developing neutropenia. However, there was no association between the development of neutropenia and hyperbilirubinemia, other immunomodulatory agents, vector-borne disease status, or the dose of vincristine used. And then this table is just a summary of all the results. So looking at signalment, hyperbilirubinemia, as we discussed, the other immunosuppressive agents used in the study, such as leflunomide and miltefosine, and the vector-borne diseases. And you can see there a few of the dogs were positive for Ehrlichia, Rickettsia, and Borrelia. With a median time to reach a platelet count of over 40,000 per microliter after vincristine administration was longer in the neutropenic dogs, which 4 days compared to 3 days in the non-neutropenic group, but this wasn't a statistically significant difference. And duration of hospitalization was significantly longer for neutropenic dogs. The neutropenic dogs were hospitalized for a median of 6 days compared to 4 days in non-neutropenic dogs. There is no difference in the proportion of dogs that died or were euthanized within 30 days of vincristine administration, interestingly. And one of the hypotheses that the paper talks about in the discussion for the duration of hospitalization being longer in neutropenic dogs is that potentially clinicians were keen to keep neutropenic dogs in for a little bit longer for intravenous antibiotics as prophylactics, and also monitoring as well. And then the study also discusses the potential causes for cyclosporine being associated with a higher risk of developing neutropenia. And in humans, we know that the CYP3A subfamily of enzymes is involved in vincristine metabolism, and humans have an increased risk of vincristine toxicosis when they receive medications that inhibit cytochrome P45, such as cyclosporine. So it's hypothesized that that could be similar in dogs as well. A study also talks about limitations of the fact that the dogs were only monitored for neutropenia for 14 days after presentation and not longer, and also that the vector-borne disease status was quite variable between the patients who were positive for vector-borne diseases, as there was a big range, and the testing was variable in terms of PCRs versus antibody testing. And then they also discussed that the lack of association between neutropenia development and dose of vincristine administered might be due to small group sizes. So most of the dogs in the study received a 0.02 mg per kg dose. However, 7 dogs received a 0.01, and then 1 dog, which is an error, received a 0.04 mg per kg dose. And that's the end. Thank you so much for listening. I'm very happy to answer any questions.